What happens when assumptions go unchecked, fear takes over, and no one's quite sure who's leading? In this shift, we unpack a real-life ICU-to-ward cardiac arrest that taught me more about communication, leadership, and psychological safety than any textbook or workshop ever could. Today, firstly, we start with a story about a cardiac arrest that didn't quite go to plan. Then we'll unpack it with Tubi and look at the way that we might have done things a little bit better. We explore what happens when teams don't know each other, how to coach in chaos, and how to work with the team you've got, not the team you wish you had. This shift is for nurses and other healthcare professionals who want to keep growing, whether you're mid-career, managing a team, or leading a service. If you're curious about nursing leadership, healthcare education, or just want to feel a little less alone in the messiness of clinical life, this one is for you. It was around 2010. It was an afternoon shift on a weekend, so there were less people around, which is kind of nice when you work in ICU. I had a patient who'd been with us for a few days in intensive care, who was now well enough to be discharged to the ward, and so we'd made plans to discharge, and I'd taken him up and handed him over to his new nurse in a medical ward, with the expectation that he would probably go home before the end of the week. A couple of hours later, there was an emergency page, and it was a code blue on the ward that I discharged my patient to, and in fact in that bed space. I arrived to the ward to find the patient having CPR with two registrars in the room. One was a medical registrar who I'd not met before, and one was the ICU registrar who I'd worked with previously, who was pretty junior at the time, and I was aware didn't have any anaesthetic experience and had never intubated a patient before. The two registrars were leading the activity. They were asking for things to happen. They seemed fairly confident in what they were doing. But I noticed all the nurses, there were 5 or 6 nurses in the room that looked scared. No, in fact, they looked terrified. They were pinned up against the wall, with as skinny as they could against the wall on the other side of the bed. There was one helping with CPR. And I brought in the drug trolley further into the room, and a nurse coordinator came in. The nurse coordinator was somebody who I'd worked with lots and lots, who I knew this was their first shift as the nurse coordinator. And I also knew while they were very experienced, they hadn't looked after an unwell adult patient for many, many years. So this was a pretty new experience for them. The two registrars seemed to kind of have things under control. They were asking for things, and a few minutes in, I'd been drawing up drugs with the nurse coordinator. The registrars decided we needed to intubate the patient. They asked for the equipment, which I'd pulled out of the trolley, and I took it over to the bed space and asked one of the other nurses, do you know how to use this equipment, and can you help intubate? And her response to me was, and I took that as, awesome, we're good to go. I've got other things to go and do over here, and I'll get the documentation and the notes happening and get the other orderlies ready to get other equipment, all those kinds of things. And I left the registrar and the nurse ready to intubate as I prepped some other drugs. And I could hear the registrar ask for the ET tube, and then she used a sharper voice and she asked, can I have somebody help me that knows what they're doing? I looked over and realised that she had the laryngoscope in. She could see where she needed to get the ET tube. And in her other hand, she held an ET tube, but it was still in the packet. So she couldn't intubate it. She was ready to go. There's no way she could undo the packet, and she couldn't put it where it needed to be. So I scurried over to help and realised that the nurse really hadn't ever done this before. I needed to put a stylet in and help prep it so that the registrar could intubate the patient, which she did very well. Then, as we'd sorted that out, I looked over and realised that I'd been told that the patient was in a non-shockable rhythm quite a few times, and we're probably now 12 minutes into this arrest, maybe even a little bit longer. But I looked over and realised that the defibrillator actually wasn't on. Now, this was prior to 2016, so we didn't follow the algorithm in the way that we do now. The drugs were a little bit more random, but we had no idea what rhythm this was in. So I got the Defib on, we actually did have a PEA arrest, and shortly thereafter we got ROSC and took the patient down to ICU. On reflection of that incident, I learned quite a lot about both communication and leadership, especially in high stakes medical emergencies. And I'm really keen to share those a little bit more now. Thanks for listening.
Hey, Naomi, what a great story. Thanks so much for sharing it with us.
Yeah, thank you. I've learned a lot since then.
We're just going to take a little bit of time to unpack some of the things that you raised in the story, and hopefully they'll be useful for our listeners, which I'm really looking forward to. So I wanted to start first with, there seem to be sort of two teams, I'll call them characters, two teams of characters. The MET team, which is you, the ICU registrar who hadn't intubated before, and the nurse coordinator. Anyone else?
So, MedReg, and then the ward nurses and the orderlies that would normally be in the team.
Okay. So it would seem to me there were quite a few challenges for clear communication in that. The first one that comes to mind for me is with those two teams, how well were you to each other? How well did you know each other in terms of skill and temperament? And how unfamiliar were the ways of working and communicating?
Yeah, so quite unfamiliar, and which is a really big part of how we work together. So I didn't know any of the medical nurses, which was unusual at the time. It would be rare for me to go into that ward and not know staff there. But on that particular shift, there was a couple that I knew by name, but I really had never worked with them. The medical registrar, I really had nothing to do with previously. So I knew the nurse coordinator quite well, but as I explained, I hadn't worked in an adult setting with her previously. We'd previously looked after neonates together. So quite a different setting. I knew the intensive care registrar to an okay level. I hadn't worked in lots of critical situations with her, but I had worked enough to kind of know her working structure.
A lot of the work that I've done in my organisation is where people are unfamiliar with each other or don't work side by side, or indeed are in different professional groups, that often from the get-go sets up quite challenging communication. You're not necessarily aware of people's understanding, their level of expertise, their level of experience and confidence. So that can be quite challenging as well.
Yeah, it's pretty tough. And when you're in those situations where it's high stakes, high stress, trying to work out what everyone's skill set is really challenging. And I've been in situations since where that's been challenging, but I've learnt since then that there are ways to get to, what skills do you have and what can you do, and more often even be able to coach people to be able to get a task done that they may not have done well before and may be only vaguely familiar with it.
That's an interesting thing, because you think in an emergency situation that coaching wouldn't necessarily fit, but I do think there is a place for it when it's well used.
Lots of the time it's just about getting people to refocus a little bit, take a breath and go, I know that you can do this. We're going to do this step by step. I've been in a couple of arrests where I've actually coached people through defibrillating. I'm going to do the first one and then you're going to take over. This is how we go through it. We use coached as our mnemonic to maintain minimal chest interruptions. And so most of our teams are pretty familiar with that, but sometimes it falls out of their head. So I just go through it with them once. It's written next to the Defib so they can go through it, and that works generally pretty quickly, and people can then manage quite well after that.
And to highlight what you said, being able to use the skills of the people who are with you, not the level of skills you wish they had or of people you have worked with before.
It's tricky. You do have to reevaluate and just use what you have and go with what you've got. And I guess working in an environment that is more regional, so we don't always have the latest and greatest. That's probably something that I've come to fairly quickly. And early in my ICU career, I worked in primary health, and I would switch between intensive care and primary health, which when I was in critical situations in primary health, I found that quite distressing that I didn't have all my things. But I learned that actually I can only do what I can do with what I've got. So I just have to make the most of what I've got and get on with it and actually still do a really good job. And once you get over that and go, I just need to work with what I've got and not be wishing that I had other things, then you can actually still do pretty good.
I think that's the thing, isn't it? We're trained to identify and to use and perform at a gold standard.
Absolutely.
But so much of the time we don't have that gold standard. We've got what's in front of us, and how do we make the best of that? So I think one of the other things that really leapt out at me from your story was the influence of assumptions and biases. What were some of those that you wanted to highlight?
Oh, look, there's a few, isn't there? So assuming that things had been done, there's lots of phrases about assumptions. It makes an ass out of you and me, or assumptions the mother of all F-ups. It's so easy just to assume that things are happening a certain way and they're actually not. And when your brain is full of lots of things going on, it's really easy to want to assume some things because it reduces your cognitive load. So we do it all the time. And part of that is self-protective. But if we don't question some of those things, we run into trouble. The most standout point here is probably the fact that the Defib wasn't actually on, which may or may not have played much difference in this particular case. It probably was a PEA, maybe even asystole arrest initially. So Defib probably wouldn't have changed the outcome, but it would be nice to know that we followed the right algorithm and at the right time. And had it have been a shockable algorithm, it would have made a really big difference because we didn't have the Defib on. Just assuming because the words were, he's in a non-shockable rhythm, I assumed that they'd actually checked, and they hadn't. I didn't ever go back and ask why, what made you assume that it was a non-shockable? Had they had the Defib one before I arrived in the room? I don't think so. What had led them to that assumption, that they'd made that assumption or that statement?
How do we help them to learn and grow from that experience as well? I do want to ask you what you do differently, but there's a couple more things that I think were challenging for communication. It's always a big one that we don't always address or identify, but emotions. I think fear is a really normal response in that kind of situation, particularly if you're not used to seeing cardiac arrest. But even if you are, there's always that sort of nugget of fear within your belly as you're doing what you know you need to do.
Yep.
I think expressions of fear can vary enormously. There's fight, flight, freeze. Sounded like there was a fair bit of freezing.
There was quite a lot of freezing in this, in this situation. So flight is a common one, and people will run. In this one, absolutely, there were 5 people frozen up against the wall who really eyes as big as saucers and just stuck against the wall. We talk about psychological safety. And when I approached the nurse and said, look, can you help with the intubation? And do you know what to do? There actually wasn't another response that she could give because she was too scared. And I see this a lot when we do advanced life support training is people will ask the person on the airway, are you happy? Are you comfortable? There isn't a response that they can give that's safe or that they can even articulate. They probably can't make any words, let alone say, dude, I've never done this before. This is crazy. Or they're stuck with I'm in this critical situation. I'm supposed to be trained. I'm really scared, but I know I have to do something. So the only real response they can kind of say is, They can't say, no, like, dude, I'm out of here. They can't say, I've got no idea. There isn't really another safe response. So that's one of the things that I would do really differently now is I would use the words, have you helped with an intubation before? And I would wait longer for an answer so that there's an option for stepping out. I'd probably actually assume that ward nurses probably haven't done that ever and just, can you go and draw up the next drug? This is what I need you to draw up. And I probably would have got an extra person to come along, which would be the way that our teams would work now anyway, that there would be an extra person that would come and assist. And it was unusual in this arrest actually that there wasn't somebody from theatre that was there. Those assumptions are pretty big, and the fear, it's hard to remember your name in that moment. There's so much adrenaline going that it's hard to process. And we need to recognise that when we're asking people to respond to things that actually they haven't got the capacity to really articulate a useful response.
I think there's also some advantages to being in the Met team or being part of the team that comes to an arrest, in that you're using some of your adrenaline up from the moment that call is made by actually getting yourself from where you are to where you need to be physically. And that's just settling things down for you. Whereas if you're on site, you're not necessarily getting that opportunity. And if you know you need to do something, but you're not sure what you need to do, I think that just creates a bit of a spiral for people as well.
And I think you're right, it's different. The team that's coming actually preps a little bit on the way, so they know what types of things they're going to. They don't know the scenario exactly, but they know I'm being called to an emergency. Whereas the team that are on the ward have a different response. They see the team come in and go, oh, thank goodness, I don't have to be the knower anymore. I can just be told what to do. I don't have to think what to do. And so there's a very different shift for people in those different roles, which we need to appreciate when we step in as the team, that it's okay, that it's going to fall out of their head, and that's all right.
Most definitely. So how would you handle the situation now? What would you do differently? You talked a little bit about some slight changes in the questions you asked, but if you arrived into that situation again, take us through from the beginning. What would you do?
One of my first strategies is always to clear the space. So more space gives us more room to move. I probably would have tasked people to draw up the drugs. And nowadays we have less drugs that we're drawing up anyway, so it probably would be less complicated. But I would task two people and go, you two, rather than standing against the wall, it's going to take you longer than it will me to draw them up, but I want you to draw up 4 doses of adrenaline or whatever it is that we need. If it was now, I would actually step into that leader role and actually lead the arrest and ask lots of questions. So identify the basic life supports happening really well, really assess breathing, assess the rhythm. We would use coached, then actually task people with, let's go, have we got IV access, and really that checklist stuff. And those checklists, having an algorithm to follow, takes away a whole lot of the load that I need to carry, but just lets me work through those steps. And I would be able to do that much more effectively than I could at the time. It appeared to me that the 2 registrars kind of knew what they were doing, whereas they really didn't. And I probably underestimated my knowledge at the time and my skills, whereas now I would be quite confident that I could step into that really well. I would also be much more appreciative of people's response when they're stressed. So now when I ask people about airway, I don't ask whether they're happy. I don't ever ask that in an arrest because you're not going to get a useful answer. But I do ask, have you got chest rise and fall? Is there resistance? And then when we've been there for a few minutes, I might be able to ask, have you done this before? Have you ever intubated? Okay. How much experience have you got? And get them to articulate that a little bit more and work out who the most appropriate people are on each of the tasks. My big things is just to take some leadership, be really clear about what activities need to happen and articulate what's going to happen next so that everybody in the room is really clear about what that means. And I would offload the equipment. So I probably got quite caught up in the drugs and the organising equipment to go back down to ICU, whereas I would offload that now and get other people to do that doing. I would stay with the people and retask who was there and what they needed to be doing.
It's quite a different approach, isn't it? And the more training I did and the more I learned, the more confidence I felt to step into that leader role, to have that overview of okay, what are you doing? What are you doing? What's our rhythm? And just be directing the traffic a little bit more. What advice would you give someone if they didn't have necessarily that training or expertise? Maybe they weren't super confident, but they wanted to be involved and be useful. What advice would you give them?
Training beforehand is the most ideal. If you've got the opportunity to train, it makes it so much easier when you're actually in the situation. But if you're in a situation tomorrow and so you've got some knowledge, not as much as you'd like, step in, just take a minute to really challenge your assumptions that you've made. So assess everything, and whether that's an ABCD approach, because that's the system that you follow, use a systematic approach to really assess everything, not assume, put away all the assumptions, step through each of them really systematically about what needs to happen, check people's understanding and articulate what the next things are that need to be done out loud, so that there can be a really useful conversation about everyone's shared cognitive model, that we actually are on the same page.
I think that's key, isn't it? That you're not working as independent people within a situation, but that you're actually moving together as a team.
If people can appreciate that shared cognitive model, they actually get more confident in what's happening, and then are able to articulate more clearly if they think that it needs to be challenged as well. But they'll have more confidence in the team moving forward, which is really useful.
I think there's a couple of things that certainly the evidence on emotions is that if you can identify the emotion specifically, you can down-regulate it from a physiological perspective. And so much that hangs us up about fear is the physiology that comes along with it. The neurobiochemistry stops you from thinking clearly. So even acknowledging to yourself, oh, I'm really scared right now, and it's okay that I'm really scared. I haven't been in this situation before, or for a long time, or I haven't been the senior person, whatever it is that's really heightening the fear, or it's a normal human response to be scared, because you're in that career because you care about people. And so when you're part of a experience where someone is actively dying unexpectedly, it can be very fearful. I think as well, I've certainly had an experience where I've arrived on shift into a cardiac arrest that wasn't flowing particularly smoothly at the same time as an anaesthetist. He took over leading the arrest and started to get things happening a little bit more synchronously, but also having the confidence to go, I don't know where we're at or who's doing what, but as the leader of this resus, what do you need from me right now? And that was really useful, because he said, I need this drug in this dilution in this size syringe. No problem. And he clearly had been leading before. Those specific directions can be so useful when not everybody has an overview of what's happening or what needs to happen next, because they haven't been there from the start and they're not really sure what is actually happening. As you said, delegating jobs or tasks with people with the right skill set or the capacity, right? If you've ever drawn up a drug before, you can draw up adrenaline. It's the same thing. If you've run fluids through to give someone IV fluids, you can run fluids through for IV push after the drug's been given. It was a really, really interesting story, and lots for people to take away from there. So in our show notes, we're going to give you just a little bit of a summary of what we've talked about, the key points that we've pulled out of here. But just for your own development and growth, have a look over the next week at work when you have communicated and it hasn't landed, or maybe not been as well received as you've intended, particularly around directing someone or encouraging someone to do a job or supporting someone to do a task that they haven't done before. Or maybe you're delegating a task and it's not been well understood what you've actually asked for. Just reflecting on that. What do you think the challenge was? Did you have some assumptions and biases about the person you were talking to? Did they need more teaching or directing versus coaching, or did they need more coaching versus teaching and directing? What were the emotions like? What was your emotion like? What was theirs potentially? And what's the level of psych safety? Is I think you clearly articulated, Naomi. If psych safety is low, how you check in on someone needs to be very different.
Yeah.
Great.
Thanks for listening. You can check out the show notes and find lots of further resources at bettereveryshift.com.au or via the link below. If you enjoyed today's episode or would love further information, we would love you to subscribe. And we look forward to seeing you better every shift.